Very good afternoon and a warm welcome to one and all present here. I would like to welcome all the attendees, all the doctors who have joined us today on this busy Saturday afternoon. So, let me start this meeting with giving you a context of our program, NEFFRON, which is an expert curated lecture series for physicians dealing with kidney disorders. It is an initiative by Saffron Formulations, which involves experts in the field of nephrology to share their thoughts on different topics related to chronic kidney disease management. So, with this, I would like to welcome our guest speaker for today, who is Professor Dr. Rana Gopal Singh, who has done his MD General Medicine, DM Nephrology. He has been the HOD of General Medicine and the Director of IMS BHU and a Senior Consultant Nephrology. He is a distinguished nephrologist with decades of clinical, academic, and institutional leadership experience. He has served as the head of department and director at IMS Banaras Hindu University. His clinical interests include complex kidney diseases, transplant medicine, and dialysis care. He is deeply respected for his diagnostic expertise, compassionate patient handling, and ethical medical practice. So, with this, I welcome Professor Dr. Rana Gopal Singh to address the audience on a very important topic, that is role of nutrition in diabetic kidney disease and CKD, that is chronic kidney disease. Thank you.
Thank you, Dr. Anjali. At the very outset, I seek the blessing of Lord to bless this august audience. Now, we have the first slide. Now, today, this afternoon, I'm going to talk about nutrition and chronic kidney disease. This is one of the important aspects of management of diabetic nephropathy. We have the next slide. Next. Physiological rationale for protein moderation in CKD, then they prescribe very low protein diet and transcription and the monitoring. May I have the next slide? Now, this objective. May I have the next slide? Next. Yeah. नेक्स्ट स्लाइड बदल नहीं सकते ये ओटीपी मांग रहे हैं थोड़ी देर बाद हाँ नाउ कमिंग टू मेल न्यूट्रिशन यहाँ से स्लाइड नहीं बदलेगा ना यहाँ से नहीं बदलेगा स्लाइड बदलेगा नहीं एक मिनट में पूछो मेल न्यूट्रिशन इन्फ्लेमेशन एंड एथेरोस्क्लेरोसिस versus uremic load. The protein catabolism leads to uremic toxins and increased acid load. The hyperfiltration and the proteinuria worsens. The undernutrition risk is protein restricted with adequate energy and the amino acid support. Goals is to reduce the nitrogenous waste products. So down the load on the kidney. Next. There's the next slide. Now, for dialysis patients who are on dialysis or who are on not on dialysis, especially non-dialyzed patient, especially stage 3 and stage 5, 24 guidelines says avoid high protein, that is more than 1.3 gram per kg of body weight per day. Consider very low protein, 0.3 to 0.4, are with this essential amino acids and keto and large. Doki to 2020 low protein diet, that is 0.5 to 0.4 per day, or very low protein diet 0.2 to 0.4 gram per kg of body weight per day, with essential acids and 35 to 40 kilocalorie per kg of body. KDA, gram per kg of body weight, and not for dialysis induced by metabolic stability. Dialysis patients requires higher protein because there is a increased leak of protein in dialysis, either whether it is CAPD or in the hemodialysis due to catabolic state not focus, which is not focused here. The next slide. Next, does protein restriction slow CKD progression? If you restrict the protein, does it retard the progression of CKD? The Cochran in 2020, very low protein diet reduces the progression of ESRD. Similarly, New England Journal of Medicine 2024 reported pooled trials fewer LPD from reducing ESRD. Every caution for monitoring of the malnutrition should be taken to keep this patient in order. May I have the next slide? Next. Now, what is the role of alpha ketones with very low protein diet? The mechanism of nitrogen-free free transaminase to essential mineral acids, less urea, which preserves a good on account of good nutrition. Garneta et al. In 2016 reported that very low protein diet plus keto and lard versus low protein diet reduced dialysis initiation in GFR and GFR decline. Recent meta-analysis 2001 to 2025 shows that decline or stable weight gain were supervised with the alpha keto and lags if you are supplementing in diet. Next, so alpha keto and lags plays a very important role. Next slide. Important role in patients of CKD. What about DKD especially? Diabetes consideration, diabetes kidney disease is one of the most important cause of renal failure at the moment, which supports zero point 0.8 gram per kg of body weight, avoidance of the high protein intake. Meta-analysis includes diabetic subgroups benefits from low protein or very low protein diet plus keto and lard under supervision. Plant dominant low protein diet is beneficial, lower acid load, phosphorus content. May I have the next slide? Now, coming to next next slide. Now, what is ultimately what we have to write for the patient prescription of diet to the patient of diabetic kidney disease or CKD. Choosing the protein in target. Start with zero point 0.6 to for a stable patient of stage 3 and stage 4, including DKD. Then consider zero point 0.3 zero point 0.3 to zero point 0.4 gram per kg of body weight, very low protein, plus essential amino acid plus keto lard. And then avoid more than 1.3 gram protein per kg of body weight per day. combined with sodium restriction plus BP plus glycemic control. May I have the next slide? So these are very important targets one should keep. Alpha keto analog in practice is a use along with a supervised very low protein diet to maintain the nitrogen balance. Then varies by the dose, varies from product to product, and monitor weight, then glucose level, albumin, bicarbonate, urea, and other biochemical parameters of the patient from time to time. Make the next slide. Next, now, next, so now coming to monitoring, who benefits most? Adult CKD in group 3 to group 3B to group 5 at high risk and metabolically stable, adherent and significant proteinuria despite standard care. Motivated patient. May I have the next slide? Next, avoid what we have to avoid. Avoid catabolic illnesses like pregnancy, uncontrolled hyperkalemia, this this fairly protein energy wasting, malnutrition, etc. Inadequate recourse to the renal dietitian therapy, and this should be avoided. Next, now coming to the next, and these are things one should avoid in managing. What is the take-home message? In summary, protein moderation in the core in the CKD and DKD can avoid. Number two, I mean the low protein diet, 0.6 gram per kg of body broadly recommended for very low protein diet requires this keto log plus essential amino acid supplementation under close supervision. Keto and log supplements delays in antecedent days without harming the nutrition were well executed. Then success depends on the adherence of the dietetic prescription. So these are the few things that one should remember in managing a patient of CKD or DKD. May I have the next slide? Next.
So this is the last slide.
Yeah, last
If
slide.
you
You
could
can go for
summarize
the
and
second.
yes,
Second
yes, sir,
study.
done. Yes, sir.
Yeah. Now, Anjali, you can go for the second study.
Yes, sir. So before we
Yeah.
start with the next presentation, I would like you to highlight few of the questions that has been come from the audience before the session. So, sir,
Yeah,
just
yeah.
in your general day-to-day practice, what has been your approach when it comes to nutrition in diabetic kidney disease patients?
Yeah. In diabetic kidney disease, once you are dealing with few things are general things, for example, good control of the glycemic control, good control of hypertension, good monitoring of the vitamin and fluid level. I mean, these are things. Coming to protein intake, naturally, if you are going for very low, low protein diet, gram per kg of body weight per day, or if you are going for very low protein diet like 2.2, 0.3, then add essential amino acids plus keto and lard. I mean that helps in delaying the progression of the disease. Yeah,
Okay, sir. Okay, sir. I'll just share my screen for the next set of presentation, which is in continuation the first presentation, and will address the specific role of alpha keto analog in the CKD management.
right.
Over to
Now
you, sir.
need of alpha keto and lard in management of CKD. May I have the next slide?
Yes,
Why
sir.
we should give alpha keto and lard in the management of CKD? What is the importance? May I have the next slide? This chronic kidney disease, as you know, its prevalence is around, it is very common condition, 850 million people. uh, are affected worldwide. The burden of kidney failure increasing in India. Every year, more than 2 lakh with new cases are being added, whereas our facility does not is not able to cope up with the management of this big burden because this is every year addition. Then CKD in India is often diagnosed late. That's another problem because what is the we see in the kidney disease that up to 30 or 40% kidney damage patient does not have any symptom, and normally ordinary physicians cannot catch them unless until they go for a specific test. That's why in India diagnosis is very late, and by time we diagnose, patient is already lost over 6. Lack of management after plays an important role in this. The symptoms. It is usually asymptomatic, and that's true. The CKD, late diagnosis. Yeah, the next slide. Now, next, what are the challenges in the management of CKD? Delay in the treatment due to late diagnosis or late reporting of the patient, progressive nature of CKD due to ESRD, and malnutrition and protein energy wasting. These are the three important factors for are three important challenges I can tell in the management of CKD. Next, what are the goals of treatment in CKD? Prevent or slow down the progression of CKD, maintain overall health, reduce the toxins and nitrogen substances, and balancing the intake of energy, protein, sodium, and next, next slide. Introduction. Keto, what are keto enlax? Keto enlax are amino acids are they are nitrogen free analog of essential amino acids transaminase in body to form the essential amino acids, reduce uric toxin load of the body, current uh, correct amino acid deficiency, and also delay progression of CKD, thereby delaying starting dialysis. Now the next slide. Mechanism of action is transformation essential amino acids by transamination using available non-essential nitrogen sources. हाँ हाँ वो कर रहे हैं पूरा हो गया देखिए तो yeah हो गया what is the mechanism of action transamination of essential amino acids, thereby the nitrogenous part is more eliminated. This process reduces the need for dietary protein intake, reduction of nitrogenous waste. Unlike dietary protein, alpha keto and lard do not increase additional nitrogen during the metabolism. May I have the next slide? This reduction seen in the anemia and usually the next slide. Next, yeah. So as per mechanism, these amino acids they are nitrogen free. May I have the next slide? Now coming to mechanism of action, the composition of alpha keto acids. These are the core of the medication. Each alpha keto protein correspond to a specific amino acids of each alpha keto amino acids. The calcium salt. Often these alpha keto acids are bound to calcium salt, thereby essential amino acids. In addition to the keto and lard acute keto and lard, some form factors also include the in, essential amino acids by by themselves, such as glycine, threonine, tryptophan, etc. May I have the next slide? Next, after what is need of double strength? Why is there two strength? Both strengths contain the same essential amino acids precursors, and work through the same mechanism, but they cater from different patient profiles, requirement, and complement changes. May I have the next slide? Next, what is the need for the double? The clinical indication of single and double strength of keto keto large. So single strength CKD in stage 3, stage 4, which is good drug, and in elderly patient, single strength is good enough. Whereas the double strength is especially given in stage 4, stage 5, and it causes the it advance rapid decline of GFR. This is a good choice. Malnutrition, brief transplant or the post-caloric surgery. Patient with poor adherence are those who are not taking drug regularly. So for them, double distance is a good option. Now the next slide. Next slide. Dosage. Now this single strength and double strength. One tablet for 5 kilo body, so it comes about 12 tablets a day. I mean, as per recommendation, and double strength requires about 6. Several target patients are CKD and CKD patient. And right, now the next slide. Next, now does it do? What is its function? It slows the progression of end-stage renal disease, reduces the serum urea, creatinine, and phosphate level, improves serum albumin and nutritional markers, delays dialysis, and improves quality of life in preventing the patient. Now coming to various clinical trials, you can see number of trials in 2016, like Garnita has published in journal. Then Dr. Bodio in 2012, Dr. Uh, uh, Tornio at nephrology dialysis and transplant. The publication is uh, in first study is 207 in stage 4 of CKD. May I have the next slide? Next, now other clinical trials are like KDOKI, KDIGO guidelines 2020. Then number of the like Triplan et al. In kidney blood in 2007. Like So they are all this trial ultimately suggested that using single or double strength keto enlarge has got beneficial role in patients of kidney disease. May I have the next slide? Key takeaway points are effective in slowing the CKD progression and delaying dialysis, helps reduce urea clearance and the phosphorus levels, supports nutritional status without acidifying nitrogen load, then backed by RCT and the other trials, recommendation with the low protein diet, zero point 0.6 to zero point 0.8 gram per, then it is got single strength has got one tablet and double strength has got one tablet per day. So strength is, if it is double strength, dose becomes half of the uh, or it's double of the single strength. May I have the next slide? So keto and lax are very important because it is a nitrogen-free essential amino acids which helps in the various function of the body. Thank you very much for the patient hearing.
Thank you so much, sir, for a very comprehensive presentation. So there are few questions that I would like you to address with regard to the alpha keto analog therapy that you mentioned. Sir, is there any
Yeah,
particular clinical or biological marker that you notice while starting a alpha keto analog therapy in patients?
yeah. One is that normally if you are using alpha keto, so the progression, it retards the progression of kidney. So markers are like estimation of blood urea, serum creatinine, and then GFR, and uric acid. I mean, these are the various markers that you can see. So if you use alpha keto and lax, these markers gradually, so either they become stable or they go down, they take downhill course. So this is a sort of a, and it helps the patient in delaying the progression of the CKD. Yes,
So when it comes to Indian population, you might be seeing a lot of patients with, different dietary profile and they have a completely varied diet profile. So like,
yeah,
how do you kind of counsel this patient when it comes to dietary counseling with the alpha keto analog supplementation? Is there
okay.
anything that you recommend when it comes to their daily dietary requirements?
Yeah, it's very good. Actually, we Indians, our pattern is different. Even dieting pattern, if you see in the south, they take a lot of dosa, a lot of idli, a lot of sambar. You go to Punjab, they take a lot of chapatis, and similarly, if you go to eastern part, West Bengal, Orissa, they take a lot of rice. So our dieting pattern is quite different. So actually, once you have made a formulation that I'll give this much protein, this much fat, this much carbohydrate, you find out the liking and disliking of the patient, and accordingly you fix your diet in that schedule. No use asking for take pizza, take hot dog and all that which patient does not know. So this is a very, I mean, or I will tell my clinician that first you find out what is the liking and disliking of the patient, and you should put your dietetic advice right in that framework. That is one point. And regarding keto and log, definitely it retards the progression. And whatever we just say, restrict the protein intake in patient of CKD. Or most of the patients they are taking very low protein. Even a normal person, their protein intake is very low. So what you need to, so you to find out. As such, if Indians are taking less protein, there is no point in restricting protein or asking them not to take protein. Whatever little they are taking, that they will stop and they will further go for malnutrition. So these are few things is very true for our Indian patients for in our situation. Okay.
Yes, sir. Especially when it comes to North, there are people who eat a non-vegetarian diet daily in their routine. And when it comes to a lot of vegetarian population who are having vegetarian food, they're already lack of protein. So there is
Yeah.
a complete disbalance in the type of patients in India.
Yeah.
So when it comes to dialysis, like, people go through a lot of weakness and muscle wasting. So in that case, do you recommend the dose should be made higher for alpha keto analog?
Yeah. Yeah. And Indians have been very sensitive regarding diet. Even in olden days, lot of description you'll find regarding diet. Even in one of the saying, the spiritual people say, "यथा यन यथा जैसा यन वैसा तन." जो आप खाते हो वैसे ही आपका मन होता है. So diet plays a very important role. So once our father, he was lying on the death bed, and then he was preaching good thing to the Pandavas. And what is good knowledge, all these ethical things, where it is gone, when in the whole court they were taking out, they are insulting me by taking my. So where was all this knowledge has gone? He said, because I have taken a dusitan, I have taken a bad food from the Duryodhan. That's why my mind was not good, and that's why I could not stop. So anyway, so we have got very. If you read Gita, there is already given a concept of the diet are three types: satoguni, rajoguni, tamoguni. All these non-vegetarian diets are tamoguni diet. All this good diet is sattva, and that's why if you see it, non-vegetarian person. I'm not non-vegetarian person. He is very angry, anxious, and all the time. And ultimately leads to depression. Where you go to a sadhu or sadhu person, things are quite different. So anyway, and these are few spiritual things that we should try to follow in our diet schedule. So our Indian has a lot of, and I know if you come to Banaras, I'll show there's a book where they've given this much wheat has got this much sattva, this much tamo, this much rajogun. So if you want to be really sattva, want to have good life, good peaceful life, then one should go in that path. Anyway, that's beyond the. I mean, that's just one information. Say regarding non-vegetarian, okay, they take, but our non-vegetarian is very different than the Western. Western means non-Western means in breakfast they will take this much chicken. In lunch also they will take this much got chicken. In dinner also. In Indian non-Western means once a week, twice a week, and that to one or two piece. So that does not give much allowance as for the protein intake. So we should take all these things in mind before prescribing the diet, and that's why I, in my practice, most of the Indians, I don't say don't stop taking protein. You take protein whatever you are taking because your intake is so low. What is there to stop there? So anyway, these are few tips that we should. It is for the benefit of the clinician. They should consider while prescribing the diet. Okay, madam.
Yes, sir. So, since a lot of physicians are watching this live telecast, and in India particularly, a lot of patients go to the nephrologist very late in their stage. And physicians are being the first point of contact. They are actually referring all the patients to the nephrologist. So, any message for the physicians that you would like to share for a timely referral to the nephrologist so that we do not delay the progression of kidney disease, which is happening in
Yeah.
India currently?
Yeah, in India, in kidney disease, one of the worst part is that your 40%, 30% kidney is gone. You will not have any symptom, and you go to ordinary physician. He will order for blood urea symptom. They are all normal. So by time your urea creatinine goes up, by time your 60% kidney is already gone. So that's why, unless until you give this very specific test like creatine cleanse or EGFR, you will not have an exact knowledge of kidney, how much kidney is working. So that's why we are most of the time our patients are coming very late. They are diagnosed very late, and their treatment is started very late. So they are in stage 3, 4, or 5. So that's why which one should be very careful. But question is when to refer. But here, what happens in private practice maybe may not be very ethical. It may be unethical. A patient who is a simple physician, he will it, he will practically treat all the patient of cardiology, nephrology, neurology, everything he will treat unless when patient becomes serious, he goes out of hand, then he'll say, it's a go to nephrologist, go to cardiologist. But initially he will not tell. This may be because of various reasons. Maybe if he just go on referring every patient, then this patient will go and his practice will come down. So I mean there are so many factors. So that's one of the factors that most of the doctors, though they know the patient is already having chronic renal insufficiency because of hypertension, they will not send to nephrologist. They will keep on treating till it goes to refractory hypertension, or patient has got the hypertension which has a number of complications. So, and there is so many factors. It will take very long time. So I will stop here. I will not give other causes.
Yes, sir. There
Okay.
are multiple factors actually involved that the patient go through a lot of comorbidities while they go to a
Yeah, yeah.
nephrologist. So
Right.
thank you so much, sir, for a very comprehensive presentation. With this, we come to the end of the session. And with this, I would like to propose a vote of thanks to you for taking your time out and sharing your thoughts and clinical insights with us and the audience. For the viewers, I would like to share that this is available on YouTube. The session is available on YouTube and you can watch it anytime. If in case you have any questions, you can put down your questions on the comment box. Thank you so much for taking your time and watching this particular live session. Thank you, sir,
Thank,
for taking your time and
thank you
sharing
very
your
much. Thank you
insight.
very much for
It was a
nicely
wonderful
conducting the
experience.
whole event. Thank you very much.
Thanks a lot.